Hello to all the viewers out there. My name is Jamie Dunnett. I'm a physical therapist based here in Nanaimo. I have a doctorate degree in physical therapy and certification in vestibular rehabilitation and a particular clinical interest and passion in treating patients post-concussion. So it's a pleasure to be able to make this presentation here today. This actually follows on the September 27th CME event that was hosted in Nanaimo that was on the topic of concussion. There was so much interest in the topic that my allotted time for the presentation got cut a little bit short. Hence this opportunity to share the entire presentation with those of you that are watching today. So the title of the presentation is Persistent Vestibular and Visual Dysfunction Post-Concussion, and we're also going to be looking at return to work, return to sports, and return to learn. And we'll do this by way of a case study that incorporates all those different aspects of the recovery. We'll then go on and look at the evidence for these different areas, and then we'll finish up by providing some information on local resources that are available here in Nanaimo for these patients. So, disclosure statement. So I have no current or past relationships with any commercial entities, and this learning activity, at least the CME event on the 27th, received financial support from the Nanaimo Division, Nanaimo Medical Staff Engagement Society, and the Practice Support Program. So we'll start off with a case study. So I'd like to introduce you to Pamela. So Pamela's a 36-year-old RN who works full-time at a long-term care center. She's also an avid skier, and she was hanging out outside the lodge at Mount Washington when a wayward snowboarder bailed out of control and crashed into her unexpectedly, and she fell over and she struck the posterolateral aspect of her head on a patch of ice. And immediately she felt dazed and disoriented. She didn't lose consciousness. Her husband was able to help her stand up and help her into the lodge. Upon entering the lodge, she began to feel quite disoriented, nauseous, dizzy. She felt unsteady on her feet. Husband had to stabilize her while they walked over to a chair, and this progressed over the course of the next few minutes. So they decided to head down the mountain to St. Joe's to get it checked out at the emergency department, which is a good plan of action given the traumatic nature of the injury. So the husband decided to drive, and on the way down the mountain, she vomited in the car. And when they got to the ER department and she was waiting in the waiting to see the physician, she vomited again. So the physician, knowing the Canadian CT head rules, decided to order a CT, which fortunately was negative, of her brain. He noticed some right unilateral gaze-evoked nystagmus, but there were really no red flags of concern. So he followed the best practice prescription at that point and discharged her home with reassurance that symptoms are normal after a concussion, and provided some written information to give her more information on that, on concussion in general. The expected recovery time is within a few days to a few weeks, so reassured her that she's expected to get better. Cognitive and physical rest was prescribed for 48 hours, and then the advice is to gradually reactivate such that the activity doesn't provoke an exacerbation of symptoms. He gave some medication advice on symptom management, told her about the red flags, if she notices any of these things, to follow up with urgent medical care. But basically the plan was for her to follow up with her family doctor in a few days, which she did. So she followed up with the family doctor, and at this point she was reporting headaches, dizziness, still felt her balance was quite impaired, had neck pain, and she's noticing some issues with her memory and concentration as well. So the family doctor decided to get her to fill out a symptom checklist questionnaire called the Rivermead Post-Concussion Symptom Questionnaire, which is a validated outcome tool to be used with patients post-concussion. She scored 31 out of 64 on this test, which is actually quite a high score. She had quite a high symptom load initially. The objective exam revealed some right gaze-evoked nystagmus, which was seen in the ER department as well. Had a lot of intolerance to lights in the room. She was covering her eyes, and any kind of head motion was very provocative and disturbing for her as well. But there were no red flags, so he provided a very similar course of advice as the ER physician. That initial follow-up with the family doctor, he reassured her, he gave her the expected recovery timelines. Graded activity is okay so long as it doesn't exacerbate the symptoms. Suggested that she stay off work for 2 weeks and just gradually increase her activity before going back to work. Medications for symptoms were discussed, as well as a headache self-management document, which is available on the Pathways website for all of you to check out, and suggested weekly follow-ups with him. So, compliant patient, there we go. She followed up on day 11 and day 18 as well. What she started to notice by day 18 was short episodes of vertigo. She was getting a little bit more active, and she was looking under the bed. She had a sudden onset of true vertigo. She's also reporting continuation of the memory and concentration issues, stimulus intolerance. She's been out of the house a few times and is finding the noise and the lights very bothersome. Ongoing nausea, unsteadiness, and headaches as well. Fortunately, at this point, the Rivermead scale is coming down a little bit at 26 out of 64. So hearing about the episodes of vertigo, the family doctor decided to test her for possible BPPV. And indeed, he did get a positive right Dix-Hallpike test, indicative of BPPV. The right gaze of oak nystagmus was still evident on the oculomotor screen. And he decided to use the sport concussion assessment tool, the 5th version, to get some brief objective evaluation of the balance as well as the memory and concentration, and noted that the scores on that particular test were impaired as well. So at this point, decided to make a referral to a certified vestibular therapist. The wait time in Nanaimo for that is approximately 1 week, as well as ear, nose, and throat, so otolaryngology. The wait time for that in Nanaimo is about 6 months. Continued to encourage the graded activity without significant symptom exacerbation, and suggested that she follow up with her employer and begin looking at possible accommodations to attempt to return to work. So the patient followed up on day 25 with a certified vestibular therapist, and you can see here this is the areas that the vestibular therapy focused on, and this is the actual treatment for it. So I identified the right posterior canal BPPV, and that responds extremely well to canalith repositioning maneuvers, formerly known as the Epley. That only took 1 in this case for that to be resolved. The right gaze of oak nystagmus and other signs on the clinical exam were indicative of a left unilateral peripheral vestibular hypofunction. It's important to remember that it's not necessarily just the brain that gets injured. It can certainly also be the peripheral vestibular apparatus as well, and that was the case with this patient. The treatment for that is a series of customized graded home exercises focusing on gaze stability, balance, and habituation to different forms of motion stimulus. Mechanical neck pain was identified. The best practice for that is manual therapy as well as exercise. And then the loss of function. So she's off work, she's not participating in her regular activities. So some exertional testing was performed, and I'll explain a little bit more about that later, as well as the return to work guidelines and the return to sport guidelines were also introduced to the patient and kept in mind in terms of progression. Fortunately, you can't see it here, but this says funding. Extended healthcare benefits does cover this. Fortunately, this patient had access to that. Now, the physiotherapist conducting this noted that she did have that significant intolerance to light, and the oculomotor exam, although it looked grossly normal, she was quite intolerant to a lot of the eye movements. So he suggested that she follow up with an optometrist with specialized training in concussion management as well. Fortunately, there are a few of those here in Nanaimo. So the follow-up with the optometrist identified the photophobia, particularly to fluorescent lights and screens, which emit a lot of the blue light portion of the spectrum. So blue light filter tint applied to the prescription was very helpful for this patient to be able to tolerate that. The difficulty reading, it was noted that that improved with trial of prism lenses, as well as vision therapy exercises, which is a series of oculomotor exercises that can be prescribed for eye movement. And then this intolerance to busy visual environments. There's a neat trick that optometrists sometimes use called binasal occlusion, where some translucent tape actually is put on the medial aspect of their usual lenses. and this can decrease the visual information coming from the overlapping visual fields and can make it easier for the patient to tolerate very busy visual environments, and that was indeed the case with this patient. So that was quite useful. Extended healthcare benefits as well as a combination of private pay were able to be used to fund this. So I want to make a comment on the return to work process, because this is often very complicated with these patients. So this algorithm is taken from the Ontario Neurotrauma Foundation guideline, which was published in June of 2018. And it's well worth looking at, but in a nutshell, it suggests taking up to 72 hours off to rest physically and cognitively, and then begin considering the return to work, thinking about if the patient requires a lot of physical exertion during their job. If that's the case, then it's reasonable to consider exertional testing, which can be done by a physiotherapist with expertise in concussion management. And out of that will come some suggestions about whether the return to work may need to be more gradual to manage the response that the patient has to the physical exertion. There's also a protocol, a sub-symptom threshold aerobic training protocol, that can come out of that particular test that can be useful for the patient to do. The other main consideration here is the high risk of re-injury, either for the patient itself or other kind of safety concerns that affect either that individual or the public. And if that is a concern, then it's reasonable to look at this top box here and just be thinking about restrictions, work accommodations, those kinds of things. If the return to work is tried and is unsuccessful, either because of a significant symptom exacerbation or the patient just can't tolerate or can't do the work properly for some reason, then at that point a more in-depth, more vocational assessment should be performed, likely by an occupational therapist with expertise in concussion management, looking at a much more in-depth analysis, and they will determine if a graduated monitored return to work is reasonable for the patient, and if not, then it is still important that they engage in some meaningful way in the community by way of volunteer work or other kinds of activities, so that they're not left in the lurch without doing anything, without any structure to their days, because that can be a trigger for mental health issues. So in terms of this particular case study, let's say on day 46 the return to work was initiated. Restrictions, so she's an RN, so no safety sensitive procedures with patients, so medication distribution, assisting frail elderly, walking, those kind of things were to be restricted. Limitations included bright, noisy, high stimulus environments, limiting those to less than 1 hour consecutively, as well as a maximum of 4-hour shifts. So the return plan started with 3 days per week for 4 hours per day, doing administrative data entry on unit outcomes in a quiet room. So that was a very nice accommodation that this employer was able to provide. Unfortunately, by day 56, this plan was not working out very well. There was a significant exacerbation of headaches. There was also frequent errors noticed in the data entry by the long-term care manager. So this was the trigger to get a more in-depth vocational evaluation, which was completed by the occupational therapist, looking at the cognitive, psychosocial functioning, the occupational and job-specific demands, work environment, supports, barriers to return to work, and so on and so forth. So this is expensive, obviously. Sometimes extended health care covers a portion of it. Sometimes the patient can pay for it privately. If there's an insurance company involved, be it ICBC, WorkSafe BC, or long-term disability, they get involved with funding this kind of thing for sure to encourage a durable return to work. So just to finish up the case study then, so this return to work plan was put into place by the occupational therapist following that exam. It took 8 weeks. It often takes these patients with persistent symptoms longer to get back to work, but in 8 weeks she managed to do it with input from the family doctor, the vestibular therapist, as well as the optometrist. And she was able to successfully return, although it wasn't until several months following the injury that this finally occurred. So what about returning to sports? This document here is the return to play communication tool. This is available on Pathways. It's taken out of the sports concussion management literature. It's actually a document from the Concussion Assessment Training Tool, which is a local BC initiative. But it's based on the consensus regarding return to sport following concussion. Basically, it's a stepwise protocol and can be a very useful guide as you make recommendations to your patients about how to return to ultimately sports that could conceivably result in another concussion. So basically how it works is stage 1 is tried, and if they're able to do this without symptom exacerbation, then they go on and they try this the subsequent day, increasing the heart rate, and so on and so forth. The red line over here, the difference here is this is training without contact, and this is contact practice. So this involves a potential for another concussion to be sustained. So that red line is where the GPs generally come in providing medical clearance. You want to be looking to make sure that the patient has clinically recovered from the concussion before making a recommendation that they go and potentially sustain another one. So your robust clinical assessment skills are important to make that decision at that point. So it is a guideline, and if you think about it as more of a sort of a way of progressing back towards sports, with this particular case study, so stage 2, which is light aerobic activity, well, this was started fairly on by suggesting that the patient just go out for some light walking in the community. Stages 3 and 4, this is more specific, so in this case balance and head-eye coordination activities. This was done during the vestibular rehabilitation. Stage 5, she wasn't actually cleared to go back to skiing in her case, which is her passion, and you can see until day 139. And that was at that point, it was convincing that the clinical recovery had occurred. So it took a long time before she was cleared to go back to skiing, but interestingly, here she is, she's got a helmet on. And there are some studies that suggest that wearing helmets when you're skiing can reduce the risk not only of more severe brain injuries and skull fractures, but also can mitigate the risk of concussion, which is controversial for helmets, but at least in a study with skiing, that did seem to be the case. So I'd like to take a moment and review the levels of evidence for what we saw in this case study. So what I've done is taken this out of the Ontario Neurotrauma Foundation guidelines published in 2018 that I mentioned earlier. And so it's divided, as commonly seen, level A, level B, level C. Level A being at least one RCT meta-analysis or systematic review. Level B being sort of moderate level of evidence with at least one cohort comparison, case studies, and other sorts of experimental study. And then this is more the consensus panel down here in level C. So if we look at vestibular dysfunction, you can see the top 3 all have grade A evidence to support them. So if there are symptoms of BPPV, it's important to do a Dix-Hallpike test to get that diagnosis. If that test is positive, it's important to treat it. And if there's evidence of unilateral peripheral, so actual peripheral vestibular injury, then vestibular rehab works extremely well for those patients. So those are all grade A evidence. Evaluation by experienced healthcare professional with specialized training in the vestibular system prior to 3 months injury is a recommendation that gets a level B. And then down here, the balance impairment, the hearing complaints, and the tinnitus gets less strong evidence, although they still are recommendations nonetheless worth looking into, getting it evaluated and treated if it's present. Vision dysfunction, this is an up-and-coming area that we'll all hear a lot more about. At this point, the evidence isn't robust to support it. But at this point, so vision changes are common post-concussion, so it's important to do a good clinical visual examination when these patients present. And then when assessed in a medically supervised interdisciplinary concussion clinic, patients with functionally limiting visual symptoms could be referred to a healthcare professional to be able to provide vision assessment and therapy. This is going to be an ophthalmologist or an optometrist. Both need the specialized training in how to conduct this. And vision rehabilitation essentially means vision therapy exercises and then modifications of the glasses, be it special glasses for reading, prism, tints, and so on, like we saw in the case study. So this is an emerging area that we'll likely see more of in the coming years. Return to work considerations. So this is out of a study by Cancelleri and the colleagues in 2014. But what it basically suggests is that patients following a concussion who can get back into the workplace have better health status, improved sense of well-being, greater social integration, and so on. So these are very important health outcomes versus those who remain unemployed. So getting them back into the workplace is important, and the evidence to support how we do that is, as you can see up here. So the work environment or duties, if they pose a risk, then more of an in-depth fitness for duty and job analysis is advised. So looking out for that risk for self and others. Restrictions or limitations should be considered when they're returning to work, and accommodations facilitated by the worker's employee to enable a timely return to work and a safe return to work are what's ideal and what's worth aiming for. The interdisciplinary vocation evaluation, primarily led by an occupational therapist. We looked at that in the case study. For these more complex return to work, that gets a grade B. And persistent symptoms that impede return to work, pre-injury employment, and that's where this engaging them in community activities and educational activities, giving them something to focus on when they're not working during their days is important and gets a grade B, evidence to support that. Return to play, so the return to play protocol that we discussed is still at a consensus level for evidence. And an important thing to consider with pharmacotherapy, so if it is being used to manage particularly headache, but really any kind of symptoms, that it's important to consider what would be the effect if the patient were not taking that when they're returning to an environment where they could conceivably sustain another injury. So in other words, is the pharmacotherapy masking some of the symptoms that would imply that they haven't clinically recovered and therefore are it's questionable whether they should be returning to risk of another concussion. So that's a grade C evidence. And then return to learn, so this is with the school-age kids. This can be particularly challenging as well. But there is a return to learn protocol, which I'll show you in just a minute, which gets a grade C level of evidence to follow. Additional assessment and accommodations, of course, in the school system. Developing a return to play program only after the return to learn has been initiated. So returning to learn is the priority with kids, not returning to play, although the young athlete, particularly if they sustain the concussion in the sporting arena, thinks that should be the priority. Obviously, it's not. It should be return to learn first. And then this can be a difficult discussion, but a child who has sustained multiple concussions, it's reasonable to refer them to an expert in concussion management regarding complex return to work decisions, and then at some point possibly changing sports. And that's a conversation I have with young hockey players, unfortunately, on a number of different occasions after they've had multiple concussions that have had protracted recoveries. It's reasonable to think that their brain might not be that well suited to that particular sport. So this is the return to learn protocol. Again, this is a modification for BC out of the Concussion Assessment Training Tool. It's an excellent document. It's available on Pathways. I recommend you have a copy of it in your office for when the kid and the parent shows up and the kid's having difficulty getting back to school. It gives some very focused stages that can help answer the question about what to next and what should they be working on when they're not at school. So it's a very nice document. I suggest you have a look at it. And so one of the things to understand as primary care physicians is you don't have to handle these patients alone. Certainly referring to specialists is useful, but there's a robust network of allied healthcare professionals in all communities, but certainly here in Nanaimo with a lot of talent that can help out with these patients as well. So let's look at allied health role in the management of concussion. It's important to understand with allied health that they have very specific scopes of practice. Concussion has a whole wide range of symptoms, and it's important to be specific with your referral. So what I've done is I've indicated the scope of practice for the allied health professional, and then given a list of local providers who are here who have expertise in concussion management, as well as their original discipline that they're trained in. So for physical therapy, the scope of practice certainly is headaches if it's coming from a neck or exertional source. The vestibular therapy is, as we've seen, helpful for dizziness, imbalance, nausea, that kind of thing. Physical fatigue, visual changes, orthopedic injuries, C-spine dysfunction, return to play. That's what you kind of generally associate with physio, and they can be very helpful, although it's very important to understand that physios don't get basic training on concussion in their university programs. This is a post-grad pursuit, and as you can see, some of them here in Nanaimo have gone ahead and done that and have more expertise in managing this particular type of injury. Occupational therapy, similar thing. So this is their scope of practice, as you can see over here. And there are a number of local providers with very well-trained OTs who can be helpful. Psychology, of course, the mental health piece is significant with these patients, particularly in the more persistent symptoms. This is traditionally what psychology is involved with in terms of the more specific symptoms. You can see we've got quite a few options here. Counselor, put her on there because she has a history of working with GF Strong, so has a good understanding of brain injury recovery, as well as these other psychologists. Neuropsychology, of course, traditionally they have a major role in the diagnostics of these patients as well as their rehabilitation. You can see their scope of practice, no surprises there. I didn't know until recently that there are 2 local providers here in Nanaimo, so that's very good to know that they're part of our community. Chiropractors, so this is, I guess, somewhat controversial. They can go on and take post-grad training in concussion management as well, and there are a number of courses that are set up for them. What's important, though, is that their basic training really qualifies them very well to treat spine injuries as well as orthopedic injuries. So if the headaches, the dizziness, the balance are driven by a suspected neck dysfunction, then they can be very helpful at assisting with that. And obviously neck pain associated with the injury and other orthopedic injuries as well. And they have some training, sports chiros have some training in this as well. Woodgrove Pines, and there are probably others. I'm just not familiar with all the different chiropractors in Nanaimo. Optometry, we looked at this in the case study. So kind of like chiropractors, it is important that they stay focused on the visual system. So any kind of visual changes fall under their scope, photophobia, dizziness and balance. If it's vision related, so if the GP suspects that vision is what's driving this, then it's a reasonable referral. Likewise, if return to work and learn is being impaired by vision problems, then this can be a useful referral as well. And there are 2 local providers in Nanaimo for this. So that's all falls in the private sector. I want to touch on what the public sector is able to offer these patients. So there's really 2 things. The first one is the Neuro Outpatient Rehab Program at Victoria General Hospital. How this works is you make a referral to this program. That referral is triaged. There's an interview with the patient somewhere between 2 and 4 weeks once that triaging of the referral occurs. Then they wait for approximately 4 to 6 months before they can get in for an interdisciplinary program based in Victoria that is up to 12 weeks in duration. So it's good rehab, but it takes a lot of time to get it organized. Then there's the brain injury program. This is a self-referral form, quite a complex form that the patient has to fill out. They submit it. It takes several weeks to be reviewed and the appropriate services in the community to be determined. But it's important to note that this group also funds the Nanaimo Brain Injury Society, which is a not-for-profit organization based here in Nanaimo, an excellent resource, in my opinion, quite underutilized. They really offer these patients 3 things. The first one is the Community Navigator Program. This is able to link the clients with both the formal as well as the informal services and resources that are available in the community to help them be able to move forward following their injury. And there's some one-to-one sort of peer support programs, as well as one-to-one sessions that can occur with goal setting, as well as education on the expected recovery from the injury. This is a new service. This is fabulous with Dr. Nancy Reeves. It's a group counseling for patients with brain injury. It's a 6 weeks program which started very recently. And then there are ongoing education programs, both for the individual who have suffered the injury, as well as the public and caregivers and so on and so forth on a variety of very useful topics that the patients it's free to attend all of this stuff. All of this is free for the patients. So I think it's important to think with these patients that there's a lot of different things going on with them following these injuries. It's complex. The solutions are ambiguous. The recommendation, at least in Nanaimo, where we don't have a interdisciplinary team under one roof, is to think about forming a network for these patients and having the network be surrounding the patient, keeping the patient's priorities and goals at the center, having communication between the different providers in the network to be able to help the patient move forward with their goals and the ultimate recovery. So hopefully we'll be able to excel with that as we move into 2019 and beyond. Thank you very much.